You're listening to This Week in Cardiology from theheart.org on Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for October 11th, 2019. This week, cautionary notes on the use of left main PCI and TAVR for patients with AS. First of all, I'm sorry for missing a week. There is just no way for me to maintain a quality podcast while traveling in 2 cities in Europe. First, a comment on the Venice Arrhythmia Conference, which is notable for 3 reasons, and one is the quality of the science presented. Thanks Professors Ravalli, Natali, and Themistokoulos for inviting a contrarian. The second notable of Venice Arrhythmia was the beauty of the venue. And third, and most crucially, get this, and I hope my friend Vinay Prasad is listening, swaths of faculty presenting at Venice Arrhythmia paid their own way. So the take-home is that scientific meetings can occur without lavishing benefits on the faculty. Now a note on the 14th annual PQRST conference in Rzeszów, Poland. My friend Dr. Piotr Fatima's project to bring EP science to southern Poland seems to be working. I was honored to join seriously distinguished faculty from big programs in the United States, Austria, and Poland. To my colleagues at Baptist Health in Louisville, I say, look out. Similar to last year, I've learned bunches in Poland. Now to the recent news. Once change occurs in medical practice, it's hard to recall the past. You take things for granted. For instance, I never thought I'd see the day that cardiologists, not surgeons, would treat patients with left main disease and aortic stenosis. But yet, the expansion of PCI to more advanced forms of coronary artery disease and transaortic valve replacement or TAVR to treat patients with severe aortic stenosis are a major thrust of modern-day cardiology. In recent weeks, however, long-term data on both of these techniques has awakened the medical conservative in me. Perhaps the excitement surrounding these new, novel approaches have slightly intoxicated us, such that we cannot see beyond the printed or PowerPointed words. First left main disease, then TAVR. At the TCT Congress this year, Dr. Greg Stone presented the 5-year results of the EXCEL trial in New England Journal of Medicine, published it. First, a brief preamble on left main disease. There's a continuum we're talking about here. On one end, there are patients with complex left main disease and multivessel disease. These patients do better with surgery, and they were not randomized in EXCEL. The discussion here centers on lower to intermediate risk patients with left main disease. Now recall that EXCEL was an RCT of about 1,900 patients with left main disease of low to intermediate complexity, and it compared PCI with drug-eluting stents to surgery. The primary endpoint was a composite of death, stroke, and MI. Now, overall death was a secondary outcome, and the cause of death in EXCEL was adjudicated as definite cardiovascular, definite non-cardiovascular, or undetermined. The authors note that the underlying assumption of proportional hazards were not met. Now this sounds technical, but it's simply because the hazards actually changed from the early period after the intervention, which favored PCI, while the later periods favored CABG. Now this led to what's called a landmark analysis, where the authors looked at outcomes of the 2 treatments at 3 different time periods, early, middle, and late. More on that in a minute. Now to the 5-year EXCEL results. The primary endpoint, the composite, was reached by 22.0% of the patients in the PCI group versus 19.2% of the patients in the CABG group. The 2.8% higher rate of events in the PCI arm did not reach statistical significance. The second composite outcome of death, stroke, MI, or ischemia-driven revascularization at 5 years occurred in 31.3% of the patients in the PCI group and 24.9% of the patients in the CABG group. This 6.4% higher rate with PCI did reach significance. And third, death from any cause occurred in 13% of the patients in the PCI group and 9.9% of the patients in the CABG group, and this 3.1% higher rate of death did not reach significance. These results led the authors to conclude, quote, in patients with left main disease of low or intermediate anatomical complexity, there was no significant difference between PCI and CABG with respect to the rate of the composite outcome of death, stroke, or MI at 5 years. And this sounds pretty clear-cut. I mean, it's just like the 3-year result. It looks like there's equipoise, and the heart team, along with the patient, can just choose among two equivalent options. But now I will steal a subtitle from multiple authors writing in circulation 10 months ago. Let's go, quote, beyond the printed words. A stunning discussion from the European Association of Cardiothoracic Surgery meeting, which is available on YouTube, got me interested in taking a deeper dive into this topic. Now, this discussion at EACTS included extremely contentious allegations of misconduct and conflicts. I will not discuss these as only the involved parties know the truth. I will discuss what I discovered looking under the hood of these trials. Now let's go over some critiques of Excel. The first thing to consider about this trial is its external validity or applicability. Recruiting patients for Excel was difficult. The trial completed enrollment with 38% fewer patients than planned. This was also seen in the Syntax trial, another RCT of PCI versus CABG. And the concern here is that enrolled patients in left main versus PCI trials were those whose doctors felt that they were suitable for PCI. This is a form of selection bias towards amenable patients. Thus, even if you take a rosy viewpoint of Excel's 5-year results, you still need to be cautious in making the leap that PCI of left main stenosis is non-inferior to CABG in all patients. These were highly selected patients. Now, the second point to make on Excel is that peri-procedural MI is a problematic endpoint. Consider that another major RCT of PCI versus CABG, the Noble trial, did not include peri-procedural MI, and Noble's results favored CABG. A provocative paper by Cho et al., published in JACC Interventions in 2017, found that the rates of peri-procedural MI are supersensitive to the definition of MI. This group looked at nearly 7,700 patients who received PCI and 3,200 who received CABG over the 10-year period between 2003 and 2013. These patients all had CK-MB levels available. And they found that if the second universal definition of MI were applied, the incidence of peri-procedural MIs was lower after CABG versus PCI, 3% versus 19%. If the third universal definition of MI were applied to the incidence rates of peri-procedural MI, then the rates were similar, 2% versus 3%. But, get this, if the SKY definition of MI were used, the rates of peri-procedural MI were 18% for CABG and 5.5% for PCI. Now, at the European Cardiothoracic meeting, surgeon and former author of Excel, Dr. David Taggart, showed an alternative analysis of Excel that he did with Professor Mario Gaudino. When they excluded peri-procedural MI, the results of Excel strongly favor CABG. His slide showed the odds ratio of the primary endpoint went from the non-significant 1.19 in the regular analysis to 1.44 excluding peri-procedural MI. That is 44% worse for PCI than CABG. Now, another speaker in the same session, Dr. Stephen Frems from Toronto, confirmed that the rate of peri-procedural MIs in Excel trial was indeed an outlier. His slide showed the rates of peri-procedural MI in 3 other PCI versus CABG trials. For instance, peri-op MI was 6.2% in Excel, but only 1.7% in Freedom and 2.9% in Syntax. Now, the Excel authors may counter this by pointing to an analysis of Excel published in the European Heart Journal. First author was Ben Yehuda, that showed large peri-procedural MIs are associated with worse outcomes. But I would argue if that were true, why didn't higher rates of MI in the PCI arm of Excel drive higher rates of death, either early or late? Okay, third criticism of Excel. In addition to the highly selected patients and the peri-procedural endpoint, Dr. Taggart offered another problem, and this was increasing mortality signal in the PCI group in Excel. Now, later in that session, University College statistician Nick Fremantle backed him up on his point. So Taggart went on. In Excel, at 5 years, the death rate was 13% for PCI and 9.9% for CABG. That 3.1% higher rate of death in the PCI group did not reach statistical significance, but the concern comes from looking at Figure 3 in the New England Journal of Medicine paper. This shows that the Kaplan-Meier curve for death and the differences, the higher rates of death with PCI, are accelerating over time. Taggart noted that these curves were not shown at the TCT meeting. He emphasized that higher death rates are especially problematic since the average age of enrolled patients in Excel was just 66 years. In other words, a 66-year-old may be very interested in higher death rates. Now, the authors of Excel would come back and counter this argument by saying that many of the deaths in Excel were adjudicated as non-cardiovascular. Well, here, Taggart cited Eric Topol's JACC paper from 1999, which discusses the problems with sorting out causes of death in trials that don't have autopsies. Now, another defense of Excel's 5-year results that I've seen online is that, hey, look, the 10-year results of the Syntax trial did not show a difference in mortality. But again, you got to look under the hood. Professor Nicholas Fremantle dismantled this counter-argument as he showed that the analysis of patients in Syntax that had the longest follow-up, and of course this data was buried in the supplement, it showed a statistically significant 18% higher rate of death in the PCI arm. He then pooled the two long-term trials, Syntax and Excel, and ended up with a 23% higher rate of death with PCI. This was highly significant at 0.004. Fremantle's take-home, now he's a statistician, was to say the probabilistic result was that PCI relative to CABG leads to increased mortality and longer-term follow-up, and this was incredibly useful effect. Before I wrap this up, let me add some comments on the problems with the non-inferiority design of Excel. I refer here to a classic 2011 paper by Thomas Fleming and colleagues published in the journal Clinical Trials. In Excel, you have to consider that CABG is the standard to which PCI is being tested against for non-inferiority. Surgery has been shown to be better than medical therapy based on its effect on mortality, not MI or strokes. Thus, adding MI and stroke to a non-inferiority trial dilutes the outcome effect. Remember that in non-inferiority trials, no difference is positive, so if you add outcomes unlikely to be affected by either treatment arm, you make it easier to show non-inferiority. A second point, the endpoint of non-inferiority trials should be measured at the same time that the reference has been shown to be beneficial. In the case of CABG, its advantage over medical therapy was positive at 5 years but non-significant at 3 years. So the primary analysis of Excel at 3 years is too short of a horizon. Finally, it is reasonable to look at MI or stroke signals in these trials, but these should be safety, not efficacy outcomes. So in conclusion, 3 things seem evident to me. One is that the conclusions of the Excel authors that's published in New England, that PCI and CABG for left main stenosis are similar, is too simplistic. While I recognize that surgeons have an incentive to defend their turf, a look behind the printed word in these trials suggests that CABG is the superior therapy in the long term. These analyses give pause to the growing notion that PCI and left main disease is an acceptable alternative to surgery for younger patients. And most crucially, I see a larger lesson here is that clinicians mustn't settle for the top-line results and conclusions of publications. Deeper dives into the data are not a simple academic exercise. They're needed to better inform our patients. Now, the next topic is TAVR versus SAVR. The TCT and European Cardiothoracic conferences also brought a bit of caution to the rush to accept TAVR before surgical aortic valve replacements in patients with severe AS. At both conferences, Dr. Vinod Thorani presented 5-year results of the PARTNER 2A, an RCT comparing TAVR versus SAVR in 2,300 intermediate surgical risk patients. The primary endpoint was death or stroke, and this was a non-inferiority trial, but a few crucial points about PARTNER 2. First, nearly 1 in 4 patients who received a TAVR in PARTNER 2 had it done transthoracically versus transfemoral. I say this is crucial because transfemoral clearly outperforms transthoracic, and more than 90% of patients who have TAVR currently in the U.S. have it done via the leg. The second point was that the version of the SAPIEN valve used in PARTNER 2 has been improved, and the newer valves associate with less valvular regurgitation. Third, valve sizing in PARTNER was done with echo, and we now know that CT imaging is superior. And finally, significant numbers of patients in PARTNER 2 were lost to follow-up, and these were imbalanced. After 2 years of PARTNER 2, the primary endpoint was 19.3% in the TAVR group and 21% in the surgery group. This was clearly non-inferior. And on the surface, Thorani's slide on the main ITT results of PARTNER 2 after 5 years also show non-significant results. Death and stroke, 47.3% in TAVR versus 43.4% in surgery. Hazard ratio 1.09, p-value not significant. Similar results with death. However, the landmark analysis gets interesting. If you look at the first 2 years, death plus strokes are numerically lower with TAVR. But then if you look at 2 to 5 years, the Kaplan-Meier curves switch. And now the primary endpoint is nearly 7% higher for TAVR. And the hazard ratio is 1.27 with a confidence interval of 1.06 to 1.53. This means that TAVR could be either 6% to 53% worse than SAVR. Importantly, the curves also show acceleration of the worst outcomes with TAVR over time. TAVR is looking worse. Of course, this overall look includes the nearly quarter of patients with transthoracic TAVR, a method we know is inferior. Indeed, Thorani showed analyses confirming the lack of hazard signal in the group of patients done with transfemoral valves. One likely cause of why TAVR underperformed in the latter half of this trial may relate to higher rates of moderate to severe AI at 5 years in the TAVR arm. Again, this may be mitigated with newer valves. Thorani did say in his concluding remarks that the current findings mandate re-examination of later time points, and follow-up in PARTNER 2A has been extended to 10 years. His ultimate conclusions, however, took into account the unchanged non-inferior results, and he noted that TAVR should be considered an alternative to surgery in intermediate risk with severe AS. But enter statistician Nick Fremantle again. Here, the European Cardiothoracic Surgery organizers asked him to comment on the problem of loss to follow-up in PARTNER 2. Specifically, loss to follow-up was 11.7% in TAVR arm and 20.4% for SAVR. Fremantle said that this degree of loss to follow-up was a, quote, massive challenge to the internal validity of the trial, because you don't know the factors that are causing patients to be lost, and you don't know whether these are random. He discussed how the FDA deals with loss to follow-up in pharma trials, which is extreme, but it allows knowing the worst-case scenario. The FDA says if patients go missing from the control arm, you assume they lived, and if they go missing from the experimental arm, you assume they died. And of course, this analysis strongly favored SAVR. He then concluded that the PARTNER 2 trial was highly susceptible to bias, and that a standard analysis required for drugs demonstrates a significant advantage for SAVR. Now, okay, to my interventional cardiology friends, I know this statistical view seems extreme, but the European Association of Cardiothoracic Surgery offered more on the choice between TAVR and SAVR. Dr. Fabio Barilli from Italy presented comparisons of a typical and not typical meta-analysis of the TAVR trials. He pointed out the main limitations of the current meta-analysis of TAVR was short follow-up and use of hazard ratios and relative risks. His group designed a pooled analysis from trials to 1. Evaluate the effect on mortality, 2. to examine the time-varying effect of TAVR versus SAVR and to compare the traditional meta-analytic methods with those that account for non-proportional hazards over time. Note, we've already heard about this time-varying effect with PCI versus CABG. So he looked at 6 of the eligible TAVR and SAVR trials, and his main point was that similar to the PCI and CABG trials, the assumption of proportional hazards over time was not met. Thus, if you look at the landmark data, TAVR is better than SAVR at 0 to 12 months. Then at 12 to 40 months, there's no significant difference. And at greater than 40 months, the hazard ratio goes 1.31, and there's a 31% higher mortality for TAVR. Thus, the current published meta-analyses of TAVR that show lower death are biased due to the significant heterogeneity and time-varying hazard. Now, while I don't know whether patients will do worse over time with TAVR, this finding should give us some degree of caution since we're on the cusp of offering this procedure to lower risk patients, and that data is very, very short term. One more presentation from the European meeting, registry data did nothing to give us confidence about TAVRs. TAVR proponent, Dr. Joseph Bavaria, added to Dr. Barilli's reasons to be cautious. Bavaria, who said he loved TAVR and that he in fact did the first U.S. implant, showed data from the STS ACC TVT registry. This, he said, was real-world data that was significant, not least because 100% participation in the registry is mandated by law. This database included records of 252,000 TAVR implants in the U.S. He said 4 data points gave him concern. 1, stroke rates in the registry after TAVR are stable. They've not changed in 6 years. Second, 30-day mortality has also not decreased in recent years with TAVR. The rate of TAVR disasters have not declined, and the 11.8% rate of new pacers after TAVR also has not changed in 6 years. Nothing about this registry data counters the concerns I've cited for long-term outcomes in TAVR. Third topic, another discussion at TCT gives us caution. This is on subclinical leaflet thrombus on bioprosthetic valves. At TCT, Dr. Raj Makkar presented more data on these subclinical leaflet thrombosis rates from a sub-study of the PARTNER 3. This was the low-risk TAVR trial. Recall that Dr. Makkar was involved with the initial description of these hypoattenuation leaflet thickening issues back in 2015, and again in 2017 with the RESOLVE and SAVR registries. The problem with these subclinical asymptomatic clots on bioprosthetic valves is that they likely have a negative impact on durability. If the valve doesn't open well because of leaflet thrombus, however small, it creates turbulence and increased shear stress. This is the theory. Now, Makkar's study looked at a subset of about 300 plus patients who had 4D CT scans from the PARTNER trial. At 30 days, 1 in 10 patients had hypoattenuated leaflet thickening, now given the name HALT, as well as reduced leaflet motion. About half of these lesions resolved spontaneously, but at 1 year, about 24% of patients had new hypoattenuated leaflet thickening. None of these thromboses were directly correlated with an MI or death, though the pooled rates of death, stroke, TIA, or systemic embolism were numerically higher in patients who had HALT versus those that did not, but it did not reach statistical significance. Now, it wasn't just TAVR valves that are affected. In the per-protocol population, the incidence of HALT was significantly higher after TAVR than SAVR, 13.3 versus 5%. But at 1 year, the rates of thrombosis were similar, 27 versus 20%, not significant. Now, Dr. Makkar made this comment, quote, "The overall message is that even though it is present so frequently, because there is no clear-cut association with life-threatening clinical events, there is no argument for routine anticoagulation to prevent these." Similarly, he said, no argument, no recommendation can be made for doing routine CTs in patients. Journalist Patrice Wendling was at the presentation and press conference, and she offers great coverage of the comments, which mostly surrounded the need for or duration of post-valve anticoagulation. I worry more about the issue in terms of its effect on valve durability over time, and here I agree with trialist Dr. Michael Mack, who said, quote, "The other shoe that hasn't dropped is its long-term effect on structural valve deterioration." In summary, friends, I now see TAVR differently. Yes, the increasingly higher outcomes with TAVR and PARTNER 2 could be explained away by the use of the older valve, lack of CT imaging, and high use of through-the-chest implants. But this data is fragile. We can't use classic meta-analysis because the treatment effect seems to vary over time. These Kaplan-Meier curves are inverting, and we don't have much long-term data. The real-world data that Dr. Bavaria showed little to no improvement in major outcomes such as bleeding, stroke, and complications in pacers. And I don't see TAVR outcomes improving in the real world as more and more of these procedures will be done at low-volume centers. The medical conservative feels like this significant uncertainty warrants extreme caution, especially when we're using this in low surgical risk patients. Yes, perhaps iterative changes in the valve will prevent the pattern of results that we're seeing in the landmark analysis of PARTNER 2, but maybe it won't. And if it doesn't, and we've implanted hundreds of thousands of these valves in younger, low-risk patients, this would be a terrible thing indeed. Obviously, all patients are going to desire a less invasive approach, but I think they should understand the uncertainties that I just discussed. Finally, before I close, I want to point you to a beautiful feature piece from interventional cardiologist Jaya Malidi. She writes about a patient who she saw who had chronic stable angina, a positive stress test, and they together chose medical therapy, and then the primary care doctor called her up and asked, "Hey, why no cath?" She explains the evidence and delves into the reasons why reflexive patterns such as chest pain equals stress test and abnormal stress equals cath get going. She reviews one of the most important medical books of the century, and this is Kahneman's Fast and Slow Thinking. Take a look at this, and it's a joy to have another medical conservative thinking publicly on the Heart.org and Medscape Cardiology. So that's it for this week in cardiology, and I just want to ask, this week I went into a little bit more depth on a smaller number of topics, and so I'm interested in your feedback. Do you like this? Would you rather have 5 or 6 topics with a little shorter? Let me know. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.